Good morning, everyone. At the outset, I would like to thank the AIOS organization for giving me this opportunity. I would be speaking on microkeratome nuances for LASIK beginners, no financial disclosure to make. Jose Ignacio Barraquer was the first person who introduced manual microkeratome, and it was first used for automated lamellar keratomyolysis. And Luis Antonio Ruiz, he was the first person to introduce motorized microkeratome. So first commercially available microkeratome was automated corneal shaper. Second generation microkeratome was Dagger lamellar keratome. It was a micro precision test model. And third generation microkeratome was Hansatome, and it is commercially available from 1997. So how to choose a microkeratome? We should know the principle and working of microkeratome, know the parameters that affect the quality of the flap. Microkeratome consists of console, body, head, blade, suction ring, and foot pedal. So we can classify microkeratomes depending on non-disposable horizontal. It can be gear-driven, automated sliding, or manual. Non-disposable vertical, it can be automated or manual, or disposable, which can be cable-driven, turbine-driven, or gear-driven. Depending on movement, you can classify them into linear, such as Moria, rotatory, such as Hansatome, and pendular from Schwein. So depending on assembly, whether the assembly is pre-assembled before applying it on the eye, it is called pre-assembled or on-eye assembly. Examples are ML7 for pre-assembled, and on-eye assembly is Moria M2. It works on the principle of Randha, that is carpenter's instrument, and it is the planer which is used to fashion the wood. So during application of suction ring, we need to increase the pressure to a range of 65 mm of Hg, because we want to make the cornea flat, and this can be confirmed by the Barraquer tonometer. So in microkeratome, blade oscillates at a very high speed to and fro in a direction orthogonal to the direction of motion, and higher the oscillation speed, smoother is the cut. So these are the gear and sliding mechanisms of the microkeratome. So in Hansatome, the gear tracks of suction ring moves into the geared tracks of the head. And in Hansatome, the movement is rotatory. In Moria SBK, the motion is linear, and in this there are no gear tracks. The head slides into the tracks of the suction ring. So this is a gearless mechanism. So here the head slides into the tracks of the suction ring in a linear fashion. So this way we can create the flap. And in pendular microkeratome, there is a drop and go phenomena. The motion of the microkeratome is in a pendular fashion. The ball shape of the cutting head protects corneal center. So disposable versus non-disposable. Disposable eliminates the need for sterilization, and it requires minimal technical manipulation. Disposable instruments, they are individually packed as sterile. There is no wear and tear of head, low probability of technician or mechanical setup error, eliminates buildup of debris and potential stimulants for DLK. It's low cost, it saves time, but disadvantage is limited surgeon control over translation speed, oscillation speed, and selection of flap diameter and thickness. So the various factors which determine flap architecture, they are arcing and linear motion, quality of blades cutting edge, speed of microkeratome pass, speed of blade oscillation, and ease of pass on the cornea. So planar versus meniscus flap, SBK and newer generation microkeratome, they give us planar cut, but older generation microkeratome used to give us meniscus flap, which were thin in the center and thicker in the periphery. So this is the histological section. The lower one is the femtosecond flap, which gives us planar flap, and the upper one is from Hansatome, which gives us meniscus flap. So translation speed and oscillation speed, rate of oscillation determines the quality of flap. Higher the oscillation rate, smoother the flap, and translational speed determines the thickness of the flap. Faster the translational speed, the thinner is the flap. So depending upon translation speeds and oscillation speed, you can control the cuts per mm. And in Hansatome, there is single circular vacuum port, so risk of suction loss and pseudo suction is there. Newer generation microkeratomes such as ML7 and Moria SBK, they have four extended vacuum slits which prevent suction loss, and there is equal distribution of suction. Most current devices cut the flap with a standard deviation of 10 to 30 micron. Sub-Bowman's keratomyces, they give us thin flaps in the range of 90 to 110 micron. These are the various available microkeratomes. In which Zyoptics give us superior hinge and Amadeus give us nasal hinge, but with other microkeratome you can choose your hinge direction. Some of the complications are buttonhole in case of steep corneas, irregular thin flap can happen, short flap can occur, free cap can occur. If the size of the free cap is adequate, then you can proceed with the surgery. If it is small, then you need to abandon it. Flap undulations can lead to macrostria because of incorrect position of flap or movement of flap after LASIK. You can manage these also. Microstria you can observe, and sometimes they resolve spontaneously. DLK, it is non-infective inflammation, and the treatment is basically topical steroids. Microbial keratitis is a dreaded complication, and it has to be managed by cornea specialist or infection specialist. Epithelial growth, if there is damage to the flap edges, you can have epithelial growth. You can treat it surgically by mechanical debridement, or you can, if the growth is peripheral, you can use anti-YAG laser in the peripheral area, so treat the peripheral post-LASIK epithelial ingrowth. So limitation of microkeratome flap, it is non-uniform in older generations, giving us meniscus flap. Newer generations, SBK, they give us planar flaps. There is thickness accuracy of 10 to 30 micron. Flap diameter cannot be controlled, difficult to perform in deep set eyes, very steep flat corneas, in corneal scars, and in cases of ocular morbidity such as filtering bleb. So an ideal microkeratome give a smooth cut, options for creating flap with variable diameter, thickness, and location of hinge, easy to assemble, monitoring of vacuum pressure during the procedure, easy to operate and easy to clean, allow visualization of the cornea, and durable. And it should give predictable flap thickness. So which one to choose depends upon the choice of surgeon. Discuss with experienced surgeons, rely on published data, and check the customer service in your area. Thank you.